Welcome to the Beehive Doc Talks with Dr. Blair Rolnick. As a pediatrician and mother herself, Dr. Rolnick is here to answer your most pressing parenting questions and guide you through the tough spots.
Welcome back to Be Kind Pediatrics. We're back in the office today, and today I wanted to talk about positional plagiocephaly and helmeting. I've had quite a few patients recently ask me about helmets as well as spots on the head, and so I thought it might be a good time to talk a little bit more about what exactly is positional plagiocephaly and why are we seeing more children in helmets. So today, I think the first question really is, what exactly is positional plagiocephaly and why are we seeing children in helmets for it? So positional plagiocephaly is a little flattening in the back of the head that we most often see in children between 2 months and 8 months of age. It's pretty rare under 2 months. And really, if you're seeing flattening of the skull at birth, you should be thinking about two things. One is molding, we'll talk about that, and the other is synostosis. Okay, so let's unpack the difference between positional plagiocephaly, molding, and synostosis. So molding is what you see when babies first come out of the birth canal. Babies have very soft skulls, and their skulls are made up of a bunch of plates that have not yet fused. And the reason for that is that babies' heads need to be malleable so that they can fit through birth canals, which is very individual to each mother and changes even with the partum of each mother. So sometimes when babies first come out, they have cone-shaped heads or misshapen heads, and that can be pretty normal. That's called molding, and that will resolve with time. That's kind of in juxtaposition to synostosis, which is when some of those plates have fused prematurely. And that can happen early on, so it can happen at birth or in the first couple months of birth or all the way up to infancy. So really the importance for parents to know is if you are seeing changes in your child's skull that you feel are concerning, either flattening and or bulges, you want to let your pediatrician know so that they can do a very thorough exam and they will be feeling for those where that cranial vault might have fused, looking for ridges. They'll be taking a look at the head and seeing if it's bulging in one area and flattened on the other, and they'll be able to have a better idea whether they think this is positional plagiocephaly versus synostosis. And why that matters is two reasons. Synostosis really is not a cosmetic problem as opposed to positional plagiocephaly, and we'll talk a little bit more about that. And the other reason is children with synostosis, there are minimally invasive techniques now that can be used. And so a referral to a neurosurgeon in the context of synostosis should happen as soon as you suspect it. Because the younger the age, the more likely they are to be eligible for a non-invasive procedure. So those children should get referrals to neurosurgeons as soon as you find them, but certainly, hopefully, within the first couple of months of life. So now let's talk a little bit about what are really the concerns for positional plagiocephaly. So really, positional plagiocephaly is a purely cosmetic concern. There was a study that was recently published that showed that there was an association between positional plagiocephaly in school-age children and poorer neurocognitive outcomes. But that really is a typical presentation. As I said before, most children with positional plagiocephaly are presenting in infancy. Positional plagiocephaly that persists into a school-age child is a much different entity. And again, the study showed an association, so not necessarily that the positional plagiocephaly was causing poorer neurocognitive outcomes, but that they were associated. So still, for the vast majority of children and the vast majority of families, when we are talking about positional plagiocephaly, we are purely talking about a cosmetic concern. So I think a lot of parents want to know why they're seeing more children in helmets when they maybe in the past weren't used to seeing quite as many children wearing helmets. And I think we need to go back to the reason why the positional plagiocephaly occurs. So positional plagiocephaly, like we've been talking about, is kind of the flattening on the back of the head. And that is largely due to the fact that the baby's skulls are so soft and made of plates, and they're very malleable. And so when they spend a lot of time in a dependent position where they're having pressure on the back of their head, pressure can actually lead to flattening. Since the Back to Sleep campaign, which was started in 1992, we've seen a lot more positional plagiocephaly. We've seen a large reduction in the number of SIDS cases, which stands for sudden infant death, about a 40% reduction. but a 600% increase in the amount of positional plagiocephaly cases. However, I don't think it's all purely contributable to the Back to Sleep campaign. There's other factors that have also contributed. So, for example, time in containers. So we've seen an increase in modern technology, which is great, but that also means things like mamaroos, DockATots, strollers, car seats, which have all increased in use, also have the baby's head flat on a hard surface, which can help contribute to the development of positional plagiocephaly. And there's kind of been a shift in the way that we travel with children. So in the past, moving children around and traveling with them largely included walking and baby wearing. And we now moved more towards cars and car seats. So they're spending, again, more time in a dependent position on their head and or strollers where they're flat on their head. There's also an increased risk with twins or twin gestations because there's less room in the uterus. So they kind of have more pressure on the back of their head again. And the number of twins have also increased due to things like advances in vitro fertilization. Other risk factors include firstborn children because we believe the birth canal might be a little bit more rigid, as well as increased risk in males. And we don't really fully understand why males are at higher risk than females yet. The last risk factors kind of include vacuum-assisted deliveries, which have actually gone down recently, as well as late rolling. So children who roll later spend more time again on the back of their head, and so they're at increased risk. And then lastly, children who have torticollis. So torticollis is a tightening of your sternocleidomastoid muscle, which is right here, and that can cause abnormal head positioning, so either looking to the left or looking to the right, and that is also a risk factor potentially for positional plagiocephaly. As well as some children just have preferred sleep positions, like they always like to sleep looking to the right. And so for those children, really addressing the torticollis, and if you notice that your child is always looking to one way, trying to reposition them so that they also are looking the other way on occasion is helpful. So the next kind of natural question I get from a lot of parents is how do you reduce the risk for your child developing positional plagiocephaly? And there's a few things that you can do starting from day one. So from day one, you can start doing something called tummy time. And tummy time is really traditionally thought of where you have your baby on their tummy and they're working on their neck muscles and pushing up and strengthening those muscles. And so when they're on their tummy, they're obviously not on their backs and not in that dependent position where they're putting pressure on the back of their head. But tummy time can be more than just, on a mat on your stomach. It can be when you're in a reclined position breastfeeding. So if you feed in that position, your baby's belly to chest with you, and they're also working on neck control and head control during those times. Baby wearing can be tummy time. Really anything where your baby is off their back is tummy time. But I encourage all parents to really start, even if it's a couple seconds of tummy time, starting from the day you get home from the hospital. Most children won't love tummy time at first. It's something you do for a few seconds and you build up. I don't think the expectation that you're going to bring a newborn home and they're going to spend a few minutes on their tummy is necessarily realistic. But as long as you're doing it for a couple seconds frequently throughout the day and building on that, that's a great place to start. Other things you can kind of do is if you're starting to notice that your child has a sleep preference, like they always prefer to sleep looking to the right, switching so that they're sometimes also looking to the left. If you notice that your child seems to have any tightness where they're constantly looking to the right, let your pediatrician know so that they can check for torticollis, and they should give you some recommendations for repositioning and stretching that muscle out. And they might also recommend that you see physical therapy to help stretch the muscle out. So the next natural question I get from parents is to helmet or not to helmet. So there was a study that was done that looked at conservative therapy, which is repositioning plus physical therapy versus helmeting. And they found that conservative therapy, 77.1% of patients had resolution of their positional plagiocephaly versus helmets, which was around 94%. But then they interestingly took those patients who did not achieve resolution with conservative therapy and put them in helmets. And the proportion of those patients who were treated with conservative therapy and then put in helmets, they had about a 96% resolution. Really, this study tells me a few things. One, that it's okay to start with conservative management first if you would like. Two, that helmets are highly effective, but so is conservative management. But helmets, again, 94% versus 77%. And then lastly, that it is okay to do conservative management, which is repositioning and physical therapy first. And if that doesn't work, then switch over to a helmet. Some other factors that I think kind of play into your decision whether you want to pursue helmeting therapy are you kind of need to know a little bit about what goes into and what are the expectations for helmeting therapy. So if you're going to helmet, really a recommendation or referral to a neurosurgeon should be done somewhere between 4 and 5 months of age. And the reason for that is most neurosurgeons will not recommend a helmet before 5 to 6 months of age because there have been some associations with poor negative sequelae with helmeting children with immature brains. So usually they're going to recommend helmeting no earlier than 5 to 6 months. And so that referral should be made around 4 to 5 months. I think the next natural question most parents have is, well, I kind of talked about how you can do conservative management and then transition to a helmet if that doesn't work. And I also talked a lot about how helmets and the malleability of the skull. Is there an age where the skull is maybe not malleable anymore and helmets are not an option? And so the answer to that is kind of multifold. So children's skulls are mostly malleable and to helmets under the age of 1. After the age of 1, it becomes slightly more difficult, but it's not impossible. So if you're going to helmet again, you kind of want to get that referral started around 4 to 5 months and then maybe around 5 to 6 months thinking about actually using a helmet. So helmets, they need to be worn 23 of the 24 hours a day. They need to be worn 7 days a week, and they need to be worn for roughly 4 to 6 months. And so kind of that information can be helpful up front when you're deciding whether or not to helmet a child, because the most common reason that helmet therapy does not work is failure to comply with wearing the helmet as frequently as it needs to be worn. And then I think the last natural question whenever you're considering any therapy are what are the risks and what are the benefits? So the benefits are mostly cosmetic, and the risks with helmeting are really not many. The most common or the risks that we really think about are consequences of wearing the helmet 23 or 24 hours a day. They tend to be worse in the summer. So that's going to be things like pressure ulcers from the helmet rubbing up against the skin, especially in those hot, humid summer months. And you can also sometimes get alopecia, which is a little bit of a bald spot if they're rubbing up against the hair frequently. But most often those bald spots are temporary and they will grow back. And then the last kind of note I want to put in there is I think a lot of parents sometimes feel like guilt or they feel embarrassed that they're choosing to put their child in a helmet for a cosmetic reason, but I don't think any parent should feel guilty for making that choice. Certainly, cosmesis has an effect on mental health later on as your child reaches adolescence and school age, and so I think parents are always trying to make the best choice for their children out there, and I fully support whatever decision you make, but I hope that this episode was helpful in providing information to help you make an informed decision.
Thank you for watching The Beehive Doc Talks with Dr. Blair Rolnick. For more episodes and her practice, visit BeKindPediatrics.com and don't forget to subscribe for more parenting tips wherever you get your podcasts. This information is for educational purposes only. It is not medical advice. Always seek medical advice from a qualified physician.